honored to be with you today, and I would like to thank the organizing committee for inviting me. I was also honored to be in the workshop this morning, so thank you very much again. My talk is about the importance of intestinal ultrasound for the radiologist. And I do not need to mention the importance of ultrasound. You all know that how non-invasive it is, and that it does not need any IV contrast. You don't have to expose your patient to ionizing radiation. So it's really very patient-friendly as well. What are the uses of intestinal ultrasound? The most important and very recently explored area is IBD, because patients with IBD have a very chronic, long-lasting disease, and they always need follow-up. So one of the important markers is ultrasound. The ECHO SGAR has recently introduced intestinal ultrasound as a cross-sectional imaging for patients with IBD on par with magnetic resonance imaging. Comparison between them has been almost equal, MRE and intestinal ultrasound. It is also very important in the ER, where you can detect acute diverticulitis, acute intestinal obstruction, or appendicitis. We have always been told that the bowel is the enemy of ultrasound. You cannot see well when there is gas. But due to recent improvements in the machines and recent interest in bowel, the ultrasound has now become one of the cornerstones in diagnosing patients with bowel disorders. What is the important part? I have to know histology in order to understand the ultrasound I'm going to see. Okay. We identify a bowel segment by its layers. First layer is the interface, the black layer is the mucosa, the white layer is the submucosa, the black layer is the muscularis propria, the last layer is the serosa. So, I have to identify bowel by finding 5 layers: black, white, white, black, white, black, white. And I should not be saying this, I should be saying hypoechoic and hyperechoic, but this is easier to understand. The most important tool in bowel ultrasound is bowel wall thickness, where diseased bowel are thick. I have to remember that diseased bowel and its thickness differs from one segment to the other. But when examined between radiologists, bowel wall thickness was the most reproducible of all the bowel. They fought for the stratification, whether uncertain or absent. They were not equal on vascularization, but the bowel wall thickness was the single most reproducible intra-observer and inter-observer. This is a segment of the small bowel with a normal bowel wall thickness, and as you can see, thank you very much. As you can see, it normally should be less than 3 millimeters in the small and large bowel. This is, you identify bowel segments also by morphology. So as you can see, this is a small bowel segment that is known by its location, central, by the presence of valves of conniventus in the lumen, and by its very thin wall, increased activity. While the colon is identified by the presence of haustrations, which are the muscular layers on the outer surface, as well as the presence of intraluminal gas. The first picture was a normal ileum, but I'm going to rush, and this is a short cineloop of an abnormal terminal ileum. And as you can see from the image, the lumen shows 5 layers. Now that the screen has stopped, 5 layers, and I have the interface, the mucosa, a very thick submucosa, a very small muscularis propria, and a thick serosa. What are my other tools? As we mentioned, the color Doppler signal is a very important tool because when there is inflammation, there is new vascularization. So the new vessels cause an increase in the color Doppler signal. So what is the normal number of color Doppler signals? Almost nothing. If I find a color Doppler signal with a thick bowel loop, this is an inflamed bowel loop. As in this image, where my bowel loop is filled with color Doppler signal. Of course, this is not a quantitative measure, it's a qualitative measure. So I say there is increased color Doppler signal, grade 1, 2, 3, spots, streaks, or in and out. Counting of bowel signals is color Doppler signal is very recent. For example, this is another markedly inflamed colon, but unlike the first one, there's no color Doppler signal. This is an improved type of inflammation, which means it could be mild or it's following treatment. You can also see that one of the important points in assessment of the bowel is the presence of creeping fat. Creeping fat is a nomenclature from CT, and since you're all radiologists, I know you understand that. The expansion of the mesenteric fat to cover the inflamed bowel. By ultrasound, I can also detect creeping fat, and I can understand that this part is markedly inflamed. It's not a good sign. Lymphadenopathy as well is a sign of inflammation. It helps to guide me to look for an inflamed bowel loop, or it can tell me that the type of disease that's causing the inflammation is this or that. As, for example, in this young male patient, this is increased creeping fat that has even accentuated the hypoechogenicity of these lymph nodes. The lymph nodes are not normal because there's no sinus in the center. By color, they were also had peripheral and central vascularization. This is the terminal ileum of the same patient, and you can see the mesenteric fat on both mesenteric and antimesenteric border, accentuating the thickness of the bowel. This is an IBD patient with Crohn's colitis. This is the colon. And as you can see, the 5 layers that we've just been talking about are absent. I can see a homogeneous bowel wall denoting severity of infection that has caused edema, disappearance of the layers. And he has increased color Doppler signal. This is a patient presenting with constipation, a young male, abdominal pain and weight loss, and as you can see, these are the 2 iliac vessels. This is the muscle, iliorectal, and this is the terminal ileum. It's markedly thickened, stenosed with a narrow lumen, and as you can see, the proximal ileum is markedly dilated, as well as an increased number of colored Doppler signals. This is a markedly active disease with stenosis of the terminal ileum. Now, this patient is very interesting. This patient presented with repeated vomiting and was by endoscopy told that he has gastritis, but by ultrasound, I found this lesion that was vascular. This was in the 3rd part of the duodenum, beneath the body of the pancreas. And I have it in several images. And this is its upper endoscopy using a colonoscope. We guided the endoscopist to change the scope in order to visualize a lesion in the 3rd part of the duodenum. This is the significance of bowel ultrasound. This is a 30-year-old male with weight loss and abdominal discomfort. And as you can see, markedly thickened terminal ileum with creeping fat surrounding the entire ileum. This patient also, these are the lymph nodes of this patient, no sinus, irregular in shape, and enlarged in size. I should consider a lymph node enlarged if it's more than 4 millimeters. This is a patient who came to the clinic complaining of uncontrolled diabetes. He said, I'm losing weight, I have uncontrolled diabetes, please prescribe medication. And when I put him on the ultrasound machine to check for fatty liver, this is what I found. I found a short colonic segment that is markedly thickened, and if you notice, more distal segment is okay. And I saw this creeping fat and a part of the ileum attached to the fat. This is an extensive malignancy, was found to have colorectal cancer by endoscopy. And this was a lymph node in the region close to the mass. This is a 40-year-old male patient, female patient complaining of abdominal pain and diarrhea. And if you can see her, this is her sigmoid colon, and it's markedly thickened. And I can see something here. What is this? This is transmural penetration, transmural ulceration with the beginning of an inflammatory mass. Of course, she had increased color Doppler signal. And if I show you this, you will see that markedly inflamed colon, markedly inflamed, surrounded by an inflammatory fluid. And as you can see here, this is a phlegm, an inflammatory mass with a small sinus, air outside. This is a lymph node here. See this lymph node? And this is a collection with air gas outside the normal human. This is a phlegm. Lastly, this patient is an elderly patient with abdominal pain, anemia, and hypoalbuminemia, and her ultrasound showed this, a long segment of completely hypoechoic wall. This is a hypoechoic wall, dilated with peristalsis, if you see that, and thickened valves in the center, maybe here, there. And this patient has small bowel lymphoma, which is characteristic, hypoechoic, no stratification, markedly thickened bowel wall, and with good peristalsis, not IBD, which would not have such good peristalsis. See, the lumen is not narrowed. I will stop here because I think they need us to go, but I will show you just this, a patient that also came with diarrhea, and if you see, this is his rectum beneath the urinary bladder, markedly thickened sigmoid colon. Thank you very much.
Thank you, Dr. Mai.